Hi, good evening. Welcome to another episode of Let's Talk About Mental Health. I'm Nels Kloster. I'm an addiction psychiatrist. I work in Southern Vermont.
And my name is Robert Stack. I'm a licensed alcohol and drug counselor. Good evening.
Right. And on tonight's show, we have a guest, Dr. Lesley Fishelman. She's a longtime colleague and friend of both Robert's and mine. And you know, it's a pleasure, Lesley, to have you on the show with us.
It's a pleasure being with you. It's really a treat.
Good. Of course, we asked her here for a reason.
Yes, we did ask you here.
We weren't just supposed to like kid around for a half hour.
No. I mean, of course, I mean, you know, around this area for expertise around pain treatment, and you've done a lot of work around that. And that was the main reason with everything that's going on these days in the news with addiction. You know, I think a full-blown heroin crisis is the way Shumlin's described it, and the connection with heroin and opiates, prescriptions for pain, and just the whole paradigm, the approach we have had to treating pain over the years that, as we've talked about privately, is really a big part of the picture we see right now.
Yeah, it really is.
So and one of the things, if you just, we were talking about it earlier, it seems as if the drug salesman set about teaching people how to use these meds. Mm-hmm. And it really came across, I mean, in a way that, now we're dealing with a heroin problem, but if you went back 5 or 10 years ago, people were exploring with pain medications. And and so now there's this evolution into the heroin. And yet it was the pain medications that got an awful lot of people started on opiates in Vermont. Mm-hmm. Really scary, the number of them available.
So as we were saying, this is a drama of unintended consequences. And I have both the fortune and misfortune of being right in the middle of this when this started. I was running a pain program in Boston for what was then the Harvard Community Health Plan. And in the early 80s to the late 80s, we never prescribed opiates at all. And the doctors in the HMO did not prescribe opiates for chronic pain. They used opiates short-term for acute pain, and then there were the oncologists who use it for cancer pain. So that I ran essentially a holistic pain management program, which worked quite well for a lot of the patients, not for everybody, but for a lot. And then what happened is, in my memory, two things. There were some articles that talked about people's misunderstanding of how addictive opiates were. And there were estimates that it was only really going to be an issue for about 1 to 5% of the population, if that. And those were probably not accurate estimates, and they were based on very small studies. And then JACO, which is the Joint Commission on Hospital Accreditation, observed that in end-of-life care and also with acute illness and acute injury, people were often being under-medicated with opiates, which I think was true. My son, Mark, broke his leg very badly, really terrible break, and had a whole bunch of issues with it. And he was on opiates for 3 days in the hospital, and they wanted to take him off. And when they did, his blood pressure went up to 250 over 120. Because they were afraid he was going to get addicted to pain medicine in 2 days or something. And I told them I was a psychiatrist, I would deal with it later, and they should give him the opiates. So there was that whole group of people who were really under-medicated. The elderly who were in pain and ready to die, so end-of-life care. People with cancer pain, and people with acute surgical or traumatic pain. Okay? But what happened is when they set the standard, they never differentiated between those things and chronic pain. And chronic pain, by definition, is something that has lasted and will continue to last. And what happened is that got glonged in or put in with these other classes of pain, and that's what created this huge issue, because unfortunately, opiates work in the short run, and by the short run, let me say, under a month. And after that, your receptor sites fatigue, and you have to have higher doses. A lot of people have to have higher doses, and then again higher doses, and they become less and less efficacious as the dose goes up. But because the standard now was to treat pain in all of its forms, the physician was caught between doing what they used to do and what they were now told to do. And this is a drama of, I think, again, unintended consequences, because the standard that was developed was not researched as carefully as it needed to be in terms of the chronic pain patient. And that's how this drama started.
Is there a point, one of the things that struck me is that when you're medicating somebody for pain and you're using an opiate and it covers the pain, but after a period of time, the pain perhaps is less, but the opiate dose is the same, even with 30-day dose. At some point it begins to have the euphoric effect that we normally associate with addiction. Not only the absence of pains, but that sense of almost well-being, if you will. And that's where truly I think it becomes addictive. And then people, is that fair to say that some people who think they're being dependent on pain medication have actually switched over to the level of they're dependent on this pill to feel good about themselves?
Well,
I mean, go ahead.
I think there is some truth to that, but actually the euphoric effects go away more quickly. So the euphoric effects are mu receptor, that's the letter mu receptor effects. And those effects fatigue quickly. And then the only way to get them, that effect back, is to raise the dose. So when you're treating somebody with opiates, if opiates work, they work pretty much at whatever dose you gave the person originally for a reasonable period of time, and a reasonable period of time can be a month or two. If what you notice is that you have to escalate the dose after whatever the initial treatment is, then you have to be very aware that you may be treating exactly what you're talking about. The antidepressant, anti-anxiety effect that worked initially wears off, so you need to escalate the dose in order for the patient to feel good. But what the patient is feeling good about is really the mood elevating effects of opiates as they're given over time in increasing doses. And even that at some point fatigues, and there's no way you can ever achieve, just like with injectable opiates, with heroin, there's no way your 27th high is going to be like your first high, because those particular features, low anxiety and high mood, fatigue first. Does that make sense?
Yes.
I mean, so that's what happens.
Right. I mean, endorphins are naturally occurring opiates. I
Right.
think most people know the endorphin effect, whether it's from exercise or love or any of these things that are healthy
Right.
and pleasurable for us.
Right.
So, quite clearly then we take these very potent opiates and they magnify, whatever we would have felt from these naturally occurring encounters.
Yeah, I think that's true, but I think what happens is when you use an exorphin, which is an exogenous or an outside agent to produce an effect similar to the endorphins, what you do in the process, and this again is unintended consequences, you suppress your body's own ability to produce its own opiates, its endorphins. So without the pill itself, you actually have less internal opioid floating around, and that's what produces the kind of dysphoria that you get when you don't have a higher dose or when you don't have the dose that you've been on. And that's the thing that actually can produce the withdrawal phenomenon.
Yeah.
So every time you take an opiate, you're doing a balancing act, because the more of it you take, the more you're suppressing your own body's ability to do what it does naturally. And it tends, this may be the American way, Americans like pills. They like pills better than self-care. And so give me a pill and I'll feel fine. Have me do exercise or meditation or yoga or some kind of consciousness training that will also elevate my opiates internally. And I'm not so interested in that. I want the quick American fix. And the quick American fix has become more and more the pill.
Well, and as you were talking earlier, it hit me that we were talking about Joint Commissions, or JACO, mandating that we take a more serious approach to treating pain, and that if we didn't treat pain, we were giving substandard care. So how did that, though, when you talk about having had a holistic clinic with many different ways of treating pain, how did that mandate become then treating pain with opioids as opposed to treating pain with holistic means?
Well, so you're in a culture which originally believed that opiates were to be used very sparingly, and again, maybe too sparingly for certain conditions. Then the culture around you changes. So our program was holistic, but the hospitals and pain clinics outside of us, particularly the ones that were in JACO, approved facilities, began to prescribe opiates. So the doctors, not so much us, the pain program, but the doctors who saw these patients originally before they came to us, because we were a referral base, we got people referred to us, we didn't see them originally, the doctors were stuck. Somebody would say, well, Dr. X at Brigham and Women's gives people this particular opiate, so why can't I have it? And there was actually a pain management specialist on the West Coast who got sued for not giving his patient opiates because he was denying them treatment for chronic pain. So the doctor was caught in a total catch-22. If I do it, it's against my best clinical judgment because I know where this is going. If I don't do it, people can complain, they can report me to the board, and they can sue me for this. And that's why it was so heartening to see that the Vermont State Board of Medicine has now given doctors permission to use their judgment about this and not be stampeded in in prescribing these medications because somebody says, well, if you don't do it, I'm going to report you to the board, which is exactly where the primary care and specialty doctors were. And so what happened is they would refer the patients to me, and I would do an opiate management kind of sort of protocol. We still did the holistic program, but again, the American way is the pill. The holistic way is more time consuming but probably a lot better for you, and so the program got sort of squeezed in that way as well.
Can I switch to addiction, if you
Sure.
don't mind? People start using opiates to get high, and the first sign of withdrawal is they get a cold, and someone teaches them it's withdrawal. But at some point with people with opiates, they get really scared of being cold turkey. They get really scared of withdrawal because it's so uncomfortable for them.
Right.
I mean, and a couple of weeks ago, a month ago, we had a question. Somebody said, I've noticed that they treat heroin addiction with Suboxone, with opiates, and yet I'm an alcoholic, and they didn't give me alcohol to keep going. What is different about that? Is that a good idea to treat opiate addiction with another opiate? And I know that we treat people with methadone and Suboxone. What's your thoughts about that? Is that something that they really need to have for an extended period of time?
Well, so this is a question of harm reduction, right? If you give people Suboxone in a supervised good program or methadone in a supervised good program, you can clearly be protecting them from the legal issues that come up with opiates, because if you're getting opiates from the street, you are almost certainly going to have legal problems, which then puts you in a whole other stream of problems that are very hard to dig your way out of. There's some people who don't have treatment readiness for the hard work of getting off these things, which once you're on them is very difficult. They're not mature enough, they haven't sort of thought about it enough, and they need support to do it. So, I don't think it's the best idea, but it's the best idea we have for a certain group of people, not people who are casually involved with opiates, but for people who really have shown that they can't do it any other way. I think it's more humane to have people on Suboxone and methadone than to have them on the street. Women, right. What happens. I mean, it's really not good.
But if you're giving them opiates on the outside, then their body's not producing the opiates. And will that become more permanent over time, or will they eventually?
It's sort of the same. So if you take opiates in a chronic way, you will become dependent on them at some point.
Right.
You will have trouble getting off of them. Same thing is true of the benzodiazepines, Valium, Librium, Xanax, Klonopin. You will get dependent on them at some point. You will have to withdraw yourself off of them. If, however, the limits are set on the opiates that you get for pain, it's a doable thing over the course of time to just slowly cut back. It's not like people shooting umpteen bags of heroin a day. Now, if you find Dr. Happy Pill, who's going to give you 180, 30 milligram OxyContin, then you're going to have the same problem that that people have with heroin. In other words, you're taking such a large dose, so many milligram equivalents of opiate, that you almost, it would take a long time to get off of it, and in that case you really need to be medically detoxed. It's very difficult for people. But no one really should be in that situation unless you're terminally ill. Mm-hmm. If you're terminally ill, and interestingly enough, that doesn't happen to people that are terminally ill. They don't need that much of this stuff. But nobody should be on that kind of dose, because there's evidence now that the higher the dose of opiate, the more your system becomes hypersensitive to any nervous stimulation at all, and you get a kind of increased pain sensitivity all over to everything. Just as you get when you go off this stuff, everything hurts. You've heard patients say
Right.
their eyelids hurt, their eyebrows hurt, everything hurts. Well, if you take this stuff for a long enough time, you get the same thing even if you're taking it. Everything hurts, and everything's worse than it's ever been. And that's a sign that if there is no acute process going on, no acute illness going on, that you need to get off them. You need to get off them.
We were talking about it, and I know you have questions too, but I just want to mention today in the New York Times, they had an article about all the deaths in Staten Island. And mm-hmm. Staten Island is this pretty much white, middle class, blue-collar workers of New York City, firemen,
right.
cops,
right.
people
right.
like that, teachers. And the number of young people dying, the number has increased amazingly. And
right.
and it seems as if young people, workers, in their 20s are dying from heroin. And
mm-hmm.
the solution, one of the solutions that they're trying to push is Nortrexon. They're trying to give Nortrexon
right.
to emergency workers and everybody else.
To keep people from dying of overdoses.
Yeah, and
yep.
give them to people, because there is so many of them, but it's sort of like they pass a Good Samaritan law. You can bring somebody to the hospital and you won't get prosecuted for
mm-hmm.
a thing. But it's almost like there's a lack of, they're naive about it. It's an opiate. And the idea with most addicts is to get higher. Mm-hmm. And I don't think people get that message. And I don't know why we didn't, somehow we failed them or something. That, we've had a patient who didn't smoke because it's bad for him, and he's doing opiates. Mm-hmm. He didn't get the message that, no, this will kill you. This mm-hmm. will destroy your life. I mean, that's been really disheartening for me. And I think a lot of people are sort of shocked that, people are doing all these opiates and they don't realize that it's going to kill you. Right. And I don't know. Right. I guess I guess Nortrexon is fine. I don't want people to die, but it's sort of like, I don't know. I wish we could stop people from trying it.
Right.
Yeah. That sounds silly.
And we've talked about that a few times too. That while there's all this attention to the epidemic, that getting people in this kind of treatment, whether it's naltrexone to prevent an overdose or getting them to methadone or Suboxone maintenance, these are sort of later levels of prevention.
Right.
To a sort of primary, secondary, tertiary, as far as stopping it from happening, making it not quite as bad, and then stopping people from dying. Mm-hmm. And we've been sort of frustrated because we think about what's a single payer system going to be like? How are we going to do primary prevention? That all these discussions around this late stage prevention, basically
mm-hmm. right.
slowing down people from dying, as opposed to looking back sort of farther in the lifespan to how we might be able to stop people from having the suffering at all.
And a lot of them lose faith in their ability to get better. Mm-hmm. I mean, I'm sure you run into that in the hospital. They quite literally have so much belief in the drug and so little belief in themselves. It's hard to convince them that, no, you can do this.
Right.
You can have a
right.
good quality life without drug. I mean, the amount of fear that they have of getting off the drug. I wish they had the fear to taking the drug that they have of getting off of it.
But most of them, most of of these people start young.
Mm-hmm.
When they have an adolescent brain, even if it's in their early 20s, you still have an adolescent brain. When you can't tell people very much, particularly men, about danger, but also women, they don't hear those messages, and there's some evidence that they're actually attracted to dangerousness. In other words, people with adolescent brains, there's something about it. And then once you get the experience, and then you keep chasing the initial experience, is the way I understand it, you're stuck, and as you say, very afraid, because in order to get out of what I tell my patients is hell, it's hell, you have to go through another kind of hell, which is to get off them, which is essentially like you have nothing left inside because you've sort of wrung it all out of yourself, and you have to go through a very difficult period, and people don't want to do that. I mean, it's the same with alcohol. And it's the same with opiates. It's the same with benzodiazepines. It's like, you play with fire and then you're really stuck. This is another example of unintended consequences, because nobody does this intending to ruin their life and to walk to live in the sewer. No one does this. I have never seen anybody who said, well, I'm gonna try this stuff, this pill, and I'm gonna, head down the tubes. Everybody thinks they're gonna get away with it, and that it'll initially improve the quality of their life, and then they get stuck.
Yeah, and we're driven towards pleasure. I mean, it's evolutionary adaptation that we go for things that feel good, taste good, and these things certainly feel good.
They do. Initially, I mean, they feel good.
But and you'll have to forgive me because I believe in the spiritual. And I think there's our kids that experiment with opiates. Mm-hmm. And I think that, there are individuals who have done opiates and walked away from them.
Right.
And have taken them, abused them. But I believe that there are some kids who have, I don't know, some form of deficit. There's something missing. Mm-hmm. And it's something that's very, very important. It's not just that they don't feel good, like they're sort of, a low depression or something. This is really an emptiness. Mm-hmm. And we heard that over and over about filling the hole, filling the emptiness. Mm-hmm. And I think for those folks, it's especially addictive.
Right.
I tell the tale, when I was going into the operating room and they were going to operate on my eye, and I'm terrified, I'm really scared they're going to operate on my eye, and they started giving me some narcotics. And next thing you know, I'm flirting with the nurse, and I'm thinking, this is good, this is a warm blanket, and I am really happy, And I just think that that's the biggest danger, is that there are people who are at a deficit. And one of the things that has to happen in recovery is you have to address that. Mm-hmm. And I think that's one of the problems when you just get off the drug. If you don't address the rest of it, you're not going to get better. I mean, I know. And I know, I'm going to put you on the spot, but I've heard you speak about spirituality, and I've heard you speak about its importance. And I wonder if you could say a little bit more about how that might be important in recovery.
Well, I think you're right about the deficit, that these drugs are probably most attractive. I think alcohol is most attractive, cocaine is most attractive to people who don't feel full in a certain sense. They don't feel full of life in a way that connects them to other people. And depending on your biology, you have a drug of choice, whatever it is. I mean, my drug of choice is food, but it can be any of these things. And you think that this particular thing will answer what is a need inside you. That's what you think. And then it does initially. It does. It answers it for the moment, right? So that what you're saying is absolutely correct. I think the problem is to get off this stuff, you go through a period where that set of feelings is actually much more intensified than it was when you started. So it's worse than it was when you originally started, because
that
you don't.
Hole sort of gets deeper.
The hole is deeper.
Okay.
The lack, the sense or perception of lack is much more powerful than it was. And one of the things about maintaining a spiritual center is that it's extremely hard to do when things aren't going well, just on the normal level. But trying to do it at that point is even harder, because in order to maintain a spiritual center, I think you need a certain level of dopamine floating around, a certain level of serotonin floating around to maintain that. So initially, that may be very hard to do unless somebody has a very, very strong spiritual center. Now, once somebody is detoxified and in treatment, then, over the course of time, these neurochemicals return to some level, and with, sort of proper support and a real desire for some object of devotion is the way I would look at something that you consider higher than you. And I know the higher power thing gets people, but the higher power can be a goal to help humanity can be the higher power, or a goal to help your family can be the higher power. But when you can generate a positive goal that you view as higher than your own needs, which I consider spiritual, then you're on your way to being able to manage. But I think that takes a certain reserve to do, to be quite honest with you. You have to have some reserve there, or a tremendous amount of support from people who have that, what we're describing. I don't know whether that makes sense.
Because typically the folks we work with, especially on opiate dependency, they don't have that reserve.
Right.
They might not have come into this sort of situation. And
right.
as you talk about this, I'm just sort of thinking about the book of Job. You know, with these awful, punishments and tests of faith, and how do you maintain a faith in the face of this pain if you've never had a faith, or how do you acquire it to make yourself? Give yourself the strength to kind of pass through what you've just described as personal hell.
Yeah, I think it takes a lot. I think it takes a lot of work, and I think the support that AA gives people is what makes AA work. In other words, they're people who figured this out, and they're people who are trying to help other people do it. And I don't think it's religious in any way. I think it's the best kind of manipulation of your own neurochemicals that's holistic. That's really holistic.
We've talked about this in another setting, is that sometimes when women discover they're pregnant, you talk about a greater good, and they decide, I want to get better.
Right.
And Nels works with pregnant women on opiates, and that was great going over there to meet them. And it was really clear that this was something greater than them.
Right.
And for whatever reason, becoming a mother, giving childbirth, this was enough of a reason to get better. This was enough of a reason to try and do something differently.
Yeah, but like we've learned too, is that especially women who say, with that power of the pregnancy, realizing for the first time they've stopped smoking, they've stopped using drugs, and then talking about the progression of the illness, they realize with that next pregnancy, oh my God, I couldn't stop.
Right.
And then just what a terror that is.
But one of the issues that we found when people are on Suboxone, once they are on a steady dose of Suboxone, the problem is they're not getting high. And they begin doing other drugs, because they still are missing that part of your life that feels good. In other words, they're not in withdrawal anymore, but they don't have like a sense of like a good life, and they're still looking to get high with a pill or a drug.
Right. So, but if the program is run properly, that would be caught, right? You would find that somebody's smoking marijuana or using cocaine or doing something. And then it's a bit easier to address right in the moment if it's done right. In other words, you say, well, you're on Suboxone, now look at this. Now, what is this?
So that's the point when the work can start.
I'm going to get in trouble. I asked you a question with 1 minute to go.
Yeah,
Okay.
we know from experience. We could talk on and on.
So,
Yeah,
and
we
on
definitely
Well, we want to thank you for coming on the show.
You're
This
very
has
welcome. It's been a pleasure.
wonderful.
It's always great talking with you guys, really.
Thank you.
It's a lot of fun.
Welcome. That's my camera.
That would be
This
my
one's
camera.
his, and this is our
Our camera. I've learned to work the camera. And when I notice at the corner of my eye, that's my face on the camera. Then I try to kind of work the camera a little bit more. You know, like I'm an expert.